All right. Welcome, everyone. We're going to get started. My name is Jill Roos from Medtronic. Thank you so much for joining tonight's presentation. Tonight, we have Dr. Nelson speaking to you about bladder and bowel conditions and the available treatment options. Dr. Nelson has been practicing in the Castle Rock area for over 7 years, and I'm excited that he's choosing to take time out of his life to come speak to you tonight. Dr. Nelson practices general urology, specializing in minimally invasive techniques and robotic surgery. Dr. Nelson is also very experienced in taking care of all urologic conditions. Dr. Nelson is passionate about educating patients on all the treatment options available for bladder and bowel control. And without further ado, I'm gonna let Dr. Nelson take over. Just one quick reminder, if you are online tonight, please ask your questions in the chat section, and we'll address those in the Q&A portion later on this evening. All right, thanks so much, Dr. Nelson.
So is there video for the people?
Yep, you're on camera. Yes.
I was just curious.
Yes.
I'm Dr. Nelson. It's really nice to see you all. I'm really grateful you guys are taking time out of your lives to either join us online or come in person to talk about this, really very important issue of bladder and bowel control. As many of you probably know, if you're taking the time, it can really affect your quality of life and your ability to live a full life. And tonight, we're gonna touch on a lot of the different issues, but really the focus of this talk is overactive bladder and urinary urgency and frequency and urine leakage because of that underlying problem, as well as bowel incontinence. And even though I'm not an expert in bowel incontinence, we will just briefly talk about some of those issues as well. And so let me see if that works. It does, perfect. So some of the questions I hear from my patients and some of the questions you guys might ask yourself: will I ever regain control? Can I attend an outdoor celebration? I'm afraid to leave home. Will I ever be able to wear white pants again? How can I possibly go on a date or get a job? And the bathroom is always on my mind. It's embarrassing. And I think despite the overwhelming response to tonight's lecture, my understanding is that 80 people signed up online, which is very telling. 50% of people with incontinence haven't ever discussed it with a doctor, and 44% of people say how embarrassed to talk they are about their bladder or bowel control problems. And I think, from a doctor's perspective, I see this all the time, and even from a personal perspective, talking to my sister, my mom. My sister's in her 40s and she says, well, I leak, but I've had kids, and it's just, part of aging, part of the process. And then you turn on the TV and you see people glamorizing pens and pads and you can look, sexy in these Depends underwear and things like that. And I think, they're trying to make money, they're trying to normalize it. And I think that for some patients, those techniques really do work well, and I have no problem with them. But I do want patients to know that you do have a choice. There are things that we could do to fix these problems. So I think it's time for a change. Bowel issues are not inevitable. And so if any of these things ring a bell for you, urinating more than 8 times a day, and that's a 24-hour day, so that includes night. Getting the have to go now feeling, you've seen the commercials, gotta go, the urgency. Planning activities around the bathroom. I hear this a lot at the mall or celebrations. Always, I'm happy to go, but I need to know where that bathroom is so that I can get there if I need to and avoid embarrassment. Monitoring or sometimes limiting how much you drink or eat, which can lead to other issues. Using pads to control leaks. Getting up multiple times at night. And I think the underlying message is that if you're having some of these problems, I don't think always, but sometimes your body, might be trying to tell you something. And you're not alone. And that may or may not be comforting. But incontinence affects people of all ages. In fact, urinary bladder control problems affect 1 out of every 6 people that you see on the street, which is 43 million adults. And bladder or bowel control, about half of that. So 1 in 12, which is about 21.4 million adults. And as we all know, ignoring bladder or bowel control problems can lead to a lot more issues. Loss of sleep, loss of confidence, loss of self-esteem, poor feelings of general health, can affect your piggy bank as well. If you're using pads and things like that, those things aren't cheap. The good news, bladder and bowel treatment can get you back to more freedom, more life, and more control. So what causes bladder and bowel control problems? There's a number of issues, but I think the most common are daily habits, including what you eat and drink. This can include caffeine, dark chocolates, spicy foods. I think we've all kind of realized triggers, alcohol, certainly. Medications or supplements that you take, pregnancy, childbirth, pelvic floor injury, can all lead to these issues. Underlying medical problems like multiple sclerosis, Parkinson's. Sometimes we don't even know. It's just, we call it idiopathic. We don't really understand why patients don't have bladder or bowel control. And those sometimes can be the most difficult to treat as well. So how does this all work? So the bladder and brain communicate, and it's essential for bladder and bowel control. And any sort of breakdown between the brain and the bladder can actually lead to bladder and bowel problems. And we all know that as we age, the connections from our brain to anywhere break down. And that's just an unfortunate part of aging for a lot of folks. And then I think we get a little ahead of ourselves here, but we talk about, unlike any other conventional treatments, the Medtronic bladder control therapy gently stimulates the nerves that go to the bladder in the pelvic area so that you can better restore that function and have better control. And the schematic here, does this have a laser pointer? Shows that the kidneys produce urine and send it to the bladder. So those are the kidneys, there's the bladder. When the bladder is about half full, it stimulates the nerves, and then the nerves signal your brain to empty your bladder. And the question I commonly get is, well, if the brain stimulates the bladder to empty, how does stimulating those nerves not make you feel like you need to go more often? And the answer is that it's actually an inhibitory signal. And I might be getting a little too technical here, but when we're babies, we just pee whatever we want. And as we age, the brain takes over and it says, now behave, bladder, we don't want you to squeeze right now. And so by stimulating those nerves, we're actually telling the bladder to behave. And so that's kind of how this technology works. For bowel control, bowel-brain communication is also essential for bowel control. And the communication breakdowns can cause bowel issues as well. And so very similar, the digestive system pushes food through the intestines. When the rectum is full, it stimulates the nerves, and the nerves signal the brain to relax the anal sphincter muscles and let you defecate. So there are three common bladder control problems that we think of in urology, and we're going to brush on all of them tonight. But the one that we really two, but the one that we're really going to focus on is overactive bladder. So the first one is stress incontinence. The second is urinary retention, and the third is overactive bladder. And we're going to go through each of those step by step. So stress incontinence is coughing, sneezing, laughing, jumping on a trampoline, exercising, anything that's increasing that pressure in your abdomen and your pelvic floor muscles aren't strong enough to hold the urine in. We call that stress incontinence because we're causing a stress that causes us to leak. It can happen when you exercise, bend, or lift, climb stairs, or stand up. And a lot of these folks, because they don't have control, or if the bladder gets too full, what they're doing is they're going to the bathroom all the time to keep the bladder empty so that it doesn't get so full that they leak. And I'll just go ahead and read the quotes. Any little thing can trigger a leak, and it's driving me crazy. Urinary retention is kind of the opposite of this. The bladder gets really full and you can't empty it. And you can imagine how frustrating that would be. The quote here is, it's incredibly frustrating to have something so simple cause this big of a problem. And I think that for most of us, we take our bladder and bowel control for granted. It's just like a normal thing until it's not. And then it can be a huge problem and cause a lot of distress. And so in this scenario, you can't tell if your bladder is full. You're unable to completely or fully empty your bladder. You might have weak or dribbling system because the bladder gets so full that that's the only way you can pee, is that it just creates so much pressure that it's able to kind of push a little bit out at a time. And that can be really frustrating. It can also be dangerous. It can cause bladder problems. It can cause kidney problems. And some folks actually need to use a catheter several times a day just to empty the bladder. And that's what we're trying to avoid. And then kind of the meat of this talk is overactive bladder. And it's kind of self-explanatory. The bladder is overactive, it's squeezing when it doesn't need to. And this can lead to urge incontinence. So you have the urge to go to the bathroom, you get out of your chair, you're on your way to the bathroom, and you leak. And that's because you've lost that control to make it all the way there. Frequent leaks after drinking, we call these triggers. After drinking a small amount of liquid, hearing or touching running water. Some people talk about using their keys in the front door, and that's a trigger. Passing a bathroom in the mall. There's a number of different triggers out there, and they're really individual. A lot of patients with these issues use protective pads and garments because it's just really hard to know when you're going to leak. And some patients say they leak without any sensory awareness at all. I don't even know. My bladder just squeezes and I leak, and then I'm wet, and I don't have any sensation. Urgency and frequency is very common. Frequent, uncontrollable urge to go, going more than 8 times per day, and feeling like your bladder's never empty. And I like everybody else, I get a little nervous speaking in front of a crowd, and I forgot to introduce Mary, who's sitting in the back, who's a nurse practitioner with our practice, who also treats a lot of these symptoms. And so I just want to introduce her now, but also say that, a lot of times the patients that come into our office, their main complaint is they say they're in urinary retention. They say, I can't go to the bathroom. I feel like I need to go. And I sit on the toilet for a half an hour, and then a little bit of urine comes out. And then I still feel like I need to go. And I sit there for longer, and a little more comes out, and then I feel better. And their idea is that they just aren't able to empty the bladder. But I think a lot of times what's really happening is they're just having that urge and that frequency and that urgency, but there's actually not enough in the bladder to really to go at all. And so it can be confusing. The quote here, I never drink anything during meetings because I'm afraid I might leak. And then fecal incontinence, which is not my specialty again, but some of the treatments we're going to talk about today can help with these issues. It's kind of self-explanatory, recurring condition with frequent accidents. And some patients have both urinary and fecal incontinence. Urge incontinence is the inability to resist the urge to go. Passive incontinence is the inability to feel when you need to go. And then these are some of the questions: planning activities around the bathroom, involuntary loss of stool, stool present every single time you urinate, stained underpants, using pads or protective garments. So it's kind of some of the same or similar issues as bladder function, but related to the bowel and stool instead. So what do we want to do? We want to find more control instead of ignoring it. And there are many ways to treat it, but there's 3 that we really focus on. And the first is lifestyle changes. The second is oral medications. And then the last one that we'll talk about is advanced therapies. So lifestyle changes, these sound simple, and sometimes they are. And for some patients, they can be very, very effective. And so we always talk about these first. These are simple solutions like diet, like we already talked about, avoiding caffeine, avoiding alcohol, avoiding fluids 3 hours before bedtime so that you can sleep through the night, avoiding really anything you put into your mouth that you notice makes you have to go to the bathroom more often. Exercise, losing weight. If you're overweight, that can affect your bladder as well. Bladder and bowel retaining, which we call biofeedback, which is a special kind of way to use your mind to control your bodily functions. And sometimes we use a physical therapist or other computers or techniques to kind of help you learn how to do that. Pelvic floor strengthening or Kegels. I feel like women are naturally good at this, or at least it seems like it. Just kind of squeezing those muscles to keep the urine in. Women have short, straight urethras, and so I think from a young age, they learn to really control the bladder oftentimes a lot better than men do. Oral medications. So like everything, we've got a pill for that. And really there are two different types of medications, and this presentation really focuses on the oldest medication that we have. It's called an anticholinergic, and it can control symptoms. It works really well for some patients, but there are a number of issues with it. Number one, you have to take it daily. If you forget, you're gonna have problems. It can also be expensive. And then the anticholinergics have really side effects that can also really affect your quality of life. Dry mouth, dry eyes, constipation, high blood pressure. And these are all issues that also happen to patients as they're aging. And so they can kind of compound on some of the issues that you're already having. I think this is a really important statistic. 72% of people said they stopped taking bladder medication within 6 months of starting it for one reason or another. Can you imagine that? And then patient dissatisfaction. So this data always surprises me, but it's been shown over and over and over. Only about 20% of patients who take the medications are extremely satisfied with their symptoms. And I think that's great. I think that if we can treat 20% of patients with medications, that's really a success. But that leaves 80% of patients that aren't extremely satisfied. They feel like things could be better, they want more. 82% of patients are non-adherent or not taking their medications 12 months after being prescribed the medications. And usually that's due to the side effects. So we talked about the anticholinergics. The new medications are called beta-3 agonists, and they work very well as, in addition to the anticholinergics. They don't have a lot of the same side effects, but they're also very expensive, prohibitively expensive for some patients, even if you've got the best insurance possible. It can be really difficult to pay for that every month, especially on a fixed income. And then this is the statistic that I really want to drive home tonight and hope that everybody attending online or in person knows that this is a process. I do not have a magic wand, nor does Mary. You know, when you come in, the first thing we need to do is diagnose exactly what is going on. Is it stress incontinence? Is it overactive bladder? Is it urinary retention and overflow incontinence? For the men, is it enlarged prostate and obstruction from that? Is it both? Is it mixed incontinence? So there's, can take us a little bit of time and some tests to kind of work through all this and figure out exactly what your issue is. And then from there, we need to move on to trying different treatments. And the first treatment we try might not always be the one that works for you. So this statistic says that 60% of patients do not return after their initial appointment. So they make the appointment, they come in, they tell you their problem, and you kind of outline a pathway, and then they never come back. 80% of patients don't return after their second appointment, and 90% of patients don't return after their third appointment. And I think that really highlights a lot of the issues we've already discussed in terms of quality of life, in terms of embarrassment, in terms of hopelessness. And so I just want to encourage everyone attending tonight to just keep coming back until we can figure out a treatment that works for you. So now we're getting into advanced therapies. So that's really kind of the meat of the talk tonight, because medications are obvious. Lifestyle change is probably not obvious, but pretty easy to look up on Google or talk about in clinic. So advanced therapies are those that we reserve if the conservative therapies don't deliver the results you expect or want. You have other options. And so under bladder control, two of them are listed there. One is Medtronic InterStim systems, which we'll get a little bit more into. Medtronic Neuro systems, and then Botox is going to be the next slide, and not on this list, but we'll talk about it. For bowel control, it's either Medtronic InterStim systems or other surgical options. And I have to believe this slide because I don't, short of the InterStim, I don't know what other options are available for bowel control. Is that it, Jill? Bowel surgery?
That's good. Yeah, surgery, right?
Yeah.
A bag. Yeah.
And the reason we talk about bowel, even though I'm not a GI doctor, is GI doctors are not credentialed to go into the operating room. And so oftentimes they will do the tests or the treatments that are available to them in their office. And then if a patient really does well with that treatment, or test and they want the device implanted, then they'll be referred to somebody like me, typically a urologist, that will place the device for them. So Botox, has anyone in here ever had Botox? All right. So the nice thing about Botox is it can make your bladder beautiful, and it can also help you with control. Injections, I think the big word here is temporarily treat the bladder control. It may raise other concerns. We use a lot of Botox in our office. I always tell patients, and I'll tell you tonight, it does mask the underlying problem. So basically we're treating the bladder right at the level of the muscle to keep the muscle from squeezing and being overactive, to hold the urine in and hopefully help with these symptoms. Depending on how much Botox we're using, we're typically injecting into 20 sites or 40 sites. So it's little injections inside the bladder. Patients typically come in every 3 to 6 months to have the treatment done over and over. The effectiveness in some studies is comparable to oral medications. It doesn't, as we already said, it's just kind of masking the underlying problem. So it doesn't address the bladder-brain communication, and it creates a potential need to self-catheterize. So as you can imagine, if we're giving Botox to the muscles to paralyze them, you could end up in a situation where the bladder can't squeeze enough to empty. And in those scenarios, patients will need to use a catheter to empty the bladder, at least until it wears off enough that the bladder starts working again. It's not a permanent problem, but it can certainly be a distressing problem. This is one of my favorites, percutaneous tibial neuromodulation. And this is one of the products that Medtronic supplies. And so we talked about that nerve that goes to the bladder and the bowel. And that nerve also goes other places. And one of those places is the tibial nerve down the foot. And it all starts in what we call the nerve root. So it's kind of got a similar place where all those nerves originate. And so this is a safe and effective, minimally invasive surgery, which is kind of a buzzword, and patients like that, and I like it too. It does reduce urgency, frequency, and urinary incontinence. It restores bladder function by gently stimulating the tibial nerve. So there's a little needle that goes near the tibial nerve and a pad that goes on the bottom of the foot, and we're sending a signal up the tibial nerve into that nerve root and hoping that it will also stimulate the nerves to the bladder. And 80% of the time, patients see real improvement. It's thought to normalize control of the bladder's natural reflexes. And then I think for a lot of patients, especially my younger, busy patients, one of the downsides is that it takes 12, 30-minute treatments. Most patients start to see some improvement after the 8th treatment or so. So we're talking 2 months of treatments with no improvement. Then we start to see some improvement, which is awesome. Again, 80% of people. And then after that, you typically need a monthly maintenance treatment, which can be a hassle for some folks. Some folks love it. I've seen it lose effectiveness after several years because it's kind of a similar treatment over and over and over, different from the treatment I'm going to talk about next. And then the last issue is that insurance companies sometimes will stop paying for it after a certain number of years. And then you're kind of forced to consider either Botox or the InterStim, which is what we're going to talk about next. Oh, my quote, PTNM has improved my quality of life. It's such a relief not to have to be worried about my bladder needs. It's a nice sense of freedom. I think we can all agree that would be the case. So this is actually my favorite treatment for overactive bladder, and I don't think it's appropriate for everybody, but I do think it's a treatment that treats the underlying problem. You don't need to come back to the office a bunch of times. And with improving technology, it can last, one implant can last up to 15 years, which is really amazing. And so like the others, it's gentle nerve stimulation, which corrects the communication pathway between the brain and the bladder bowel and restores the bladder and bowel function. It's more effective than medication. And the cool thing about this is that there's a test that lets you try the therapy to see if it works for you before you commit to doing the full surgery. And I think that's a really nice and important thing to know. If we decide to move forward, if it works for you, Then we basically place a small implant, it's about that size, in your upper butt cheek, or buttock, I guess is the proper word. And then we also have rechargeable and recharge-free devices that we can put in. And most people are going with the recharge-free devices now that they last so long, which I think is important. And you can see here, there's the device that's underneath the skin, so everything's hidden. And then there's the little wire, and it goes down right near those nerves that lead to the bladder and the bowel. So this slide just says take back control. So it's just highlighting some of the success that we've had with InterStim. Over 375,000 people have been treated worldwide, which is a really large number. The treatment starts in our office. You come in and we place a small wire in an outpatient setting into the space where the nerves are. And then we hook you up to a small battery that you can wear underneath your clothes. It's concealable, and you can wear this around and do your normal activities for up to 14 days. And we see if there's any improvement. And we want to know subjectively, which means, do you feel like there's improvement? And then we also have you record your habits on a piece of paper so we can get some objective data and say, yeah, there's real improvement here. You feel better. Scientifically, we're seeing that things are better. And then if that's the case, we go ahead and schedule the surgery and implant the device. And again, over 80% of people have it. So with the PTNS, they say up to 80% of people can enjoy some improvement. With this, they're saying 80% of people have improvement in 5 years. So 5 years out, which is pretty remarkable. One of the biggest limiting factors for this technology has been that it wasn't compatible with MRIs. Yeah. And so, you know, we get CTs and MRIs for a lot of different things now. And some people have underlying conditions, ironically, that cause bladder problems that they need MRIs to follow, like multiple sclerosis and issues like that. And so this has been one of the biggest, in my opinion, advancements in this technology, is that now we can place this device and you can still get your MRI. And I think that's a really big deal. And so just, you know, you can get full body 1.5 or 3T scans. That's just talking about the size of the magnet. 3T is bigger. They're designed to streamline MRI. So there's Medtronic SureScan systems, which are designed to streamline MRI scans. It's the only sacroneuromodulation system with this technology, which means there's no impedance checks required before MRI scans. MRI mode is easily to activate or deactivate on your little programmer. So each one of these devices has a little, looks like an iPhone, and you can control the settings, you can turn it up, you can change the program. And so getting back to PTNS, when I talked about it's kind of the same treatment over and over. The cool thing about this technology, and honestly compared to some of the other technologies, is that you're in control of the device. You can turn it up, you can turn it down, you can change the program. So instead of having the exact same gentle signal for 15 years, if it starts to lose effectiveness, you can change it to a different signal and see if that works. You can turn it up, turn it down. And to me, that's the reason that this device really stands out. So there's 20 years of MRI research, 1.2 million scanning scenarios, and 10 million simulated patient scans. So it's been tested and it's safe. So I think at the end of the day, the big question is this therapy right for you? And I think that takes some work to come to that conclusion. We need to make sure that overactive bladder, urgency, frequency, and I don't know if I'm supposed to talk about this, but in some cases, if patients have urinary retention, we don't know how or why that works, but we put an InterStim device in and all of a sudden they can pee, which is really a miracle in my opinion. So if you have significant symptoms, you've tried lifestyle changes and oral medications, I think it's important to point out that we're not trying to torture you by putting you through a bunch of different treatments before we offer you InterStim. The insurance companies actually are really specific about what patients must try and fail before we can offer any of this technology. And they make you try 2 different medications for at least 30 days. They make you do the bladder diarrhea, and then after the test, do another one, because they really want to make sure that, you know, it's going to work for you. And they want to make sure that there's not a treatment that might be less invasive or easier before we get to this therapy. And so that's one of the reasons that it takes a little bit to get through the process and see if you're a good candidate for this. So this slide just kind of drives everything home. Trust a proven therapy. 84% satisfaction among those who use it for bladder control, which is a big deal. A 3-time greater improvement in the quality of life compared to medications, which I think is a big deal. And 89% of people using Medtronic bowel control therapy also experience long-term success. So I'm not living in the bathroom, I'm living my life. And that kind of concludes